So now I've been talking about the aggressivity of the tumor, and we have developed a method, stemtrac, to assess the aggressiveness and the risk of formation of metastases. And I'll show you how we proceed. The tumor stem cells are assumed to be a subpopulation of the tumor cells with stem cell characteristics, and stem cell characteristics is self-renewal capacity and also the ability to have cells which then differentiate into a heterogeneous population. And it's assumed that these cells are responsible for tumor initiation, for progression, and recurrence and metastasis. And they are assumed to be most resistant to conventional chemo and radiotherapy, so making the current treatments often ineffective. Currently, there is urgent focus in cancer research for strategies to eradicate just these cancer stem cells. So how do we determine the cancer stem cells? Again, we take the blood you send us, we lyse the red blood cells, we take the tiny sediment and dilute it in growth medium, which preferentially leads to growth of the epithelial cancer stem cells into small spheroids, daughter cells that have been derived from doubling of the mother cell. We can then precisely determine not only the presence of such cells, but even the quantity of the circulating cancer stem cells in the blood. And here is an example how these stem cells are classified. They are CD44 highly positive, together with EPCAM staining, CD24 low positive, and in colon cancer stem cells, CD133 is a typical marker in the stem cells. And then there's additional the LDH1 test, which is positive in stem cell spheroids. And all these can be determined with the fluorescence microscope. We have published the results and think that this is able to assess the risk for metastasis formation, monitoring of therapy progress, and early detection of a possible relapse. And on the left side, this is a model how we assume that such spheroids look like and form. So this is again a report on colon cancer, but this time for the circulating cancer stem cells. And in this case, the patient, after surgery of quite large tumor again with lymph node involvement, had FOLFOX chemotherapy. And after this therapy, we did not or minimally find tumor spheres. And this is consistent with a clinical remission. This other patient had only one determination after surgery, but this 67-year-old man with colon cancer had very high circulating cancer stem cells as well as single cancer cells. This indicates a significantly increased risk of tumor recurrence. And although the patient initially declined chemotherapy, we would suggest to still do the chemotherapy. And indeed, the patient opted for adjuvant chemotherapy. So this also contributed to an optimal decision with the help of the circulating cancer stem cells. Do you have any questions at this moment?
Is there a number of circulating cancer stem cells indicating a higher risk of recurrence?
There is indeed. I've told you before that the individual circulating epithelial cells, that there is no real threshold and that it's rather the behavior of these cells which indicates that there is a risk of recurrence or no. But in the cancer stem cells, we have determined that more than 300 cancer stem cells per ml indicate an increased risk of metastasis. And if such high numbers are determined, it would be wise to do additional imaging analysis.
Another question. What is the difference and impact between therapeutic relevant cell characteristics on cancer stem cells and circulating tumor cells? Are there any differences in expression?
We have not sufficiently analyzed these markers in question. We would be able to do, for example, in breast cancer, estrogen receptor or HER2, in gastric cancer, and so on. No, we have not sufficiently analyzed these characteristics yet, so we cannot tell about how the stem cells differ from the single circulating cells and whether this has clinical impact.
All right, thank you very much.
Here I would like to show you long-term follow-up with maintrac and stemtrac. And this is a patient, a young man with metastatic colon cancer, and he was KRAS positive. He received chemotherapy before surgery together with complementary therapy, had a very good clinical response, very good response of the circulating tumor cells and the circulating stem cells, as you can see, between 0521 and 1021. He then had surgery, and after surgery, his cell numbers increased as well as the stem cells. And in 23, the PET-CT detected recurrence of metastasis in the liver. The liver lesions were ablated with a reduction in the circulating stem cells, less pronounced in the single circulating cells, which started increasing again. And in this case, there was only a small increase in stem cells. And again, liver metastases were detected, were ablated. And now in April, again, liver metastases were detected and removed. The same now here showing, in addition, CT DNA, which we also analyzed, and we could not detect any circulating DNA, although this patient had a high increase in circulating cells. So we do not know when ctDNA might be detected. It's also important to see that there were no stem cells anymore. And this may be due that the stem cells are retained in the liver metastasis, and inside the metastasis lead to a renewed growth of these metastases. Do you have any questions here?
Yes, one question. Do you have any explanation why there has been non-ctDNA but circulating tumor cells?
Yes, we have an explanation which we think is important. That is that ctDNA is released when the cells are dying and not when they are growing. So only if the metastasis has reached a size when there are cells dying inside the metastasis, we assume that ctDNA will be detectable, and we will monitoring this during the further course of this patient.
From your experience, does metastatic colon cancer patient have more or less circulating tumor cells?
Colon cancer patients usually have quite high numbers of circulating tumor cells. And as you saw, he had also for a time quite high numbers of circulating tumor stem cells.
Thank you very much.
I told you that we can also look for mutations in individual circulating tumor cells. And this we performed by using a capillary to pick individual circulating tumor cells and depositing them one for one into PCR microcups. And then we performed the mutation analysis on single cells using ampli-1 whole genome amplification to amplify the DNA of the single cell and detecting the mutation with the COBAS PIK3CA mutation test. And what we found was that in the tumor tissue, there was the mutation G to T in the KRAS, which is an activating mutation. And we found the same mutation in 4 out of 10 cells in the circulating tumor cells with exactly the same characteristics. But in addition, we also found the PIK3CA exon 20 mutation, and this is also an activating mutation. So these findings suggest that there is potentially a tumor evolution and clonal diversification during disease progression, which can be found in the circulating tumor cells. Now I've got to the end. Do you have any questions?
There's one more question currently. When can clinical guidelines or institutional recommendations regarding the use of maintrac and stemtrac in oncology be expected?
We hope that we can get the certification in about 1 year.
Currently, there are no more questions.
Okay.
So I would like to thank you all.
Thank you for your attention. And if you have further questions which may develop during time, you can always contact us at mail@laborpachmann.de, and we will try to answer your questions as fast as possible. Thank you very much.